please start. Abhijit ji.
Good afternoon, everyone. Thank you for joining us for today's webinar. Myself, Dr. Abhijit Malvi. I am medical advisor at Intas Pharmaceutical Limited. Being a science-driven pharmaceutical company, Intas is always at the forefront in providing educational platforms. Now, during this time of social distancing, webinar is the best platform for getting knowledge from experts. In this COVID pandemic, there is growing concern on how the coronavirus disease will impact those of us who are in midst of fertility treatment. To address the same, the topic for today's webinar is IVF practice in post-COVID era. And the expert with us is Dr. Kaberi Banerjee. Dr. Kaberi Banerjee is Medical Director, Advanced Fertility and Gynecology Center, New Delhi. She is the chairperson, Delhi State Chapter ISAR. She has conducted more than 8,000 IVF, ICSI donor and surrogacy cases, and she is a recipient of many awards like Bharat Jyoti Award in 2008, Global Healthcare Excellence Award in 2014, India Today Excellence Award, Prince Waterhouse Cooper Award, Economic Times Award recently in 2019, Best State Chapter ISAR Award 2019, and ISAR Champion Award 2019. She is also the founder of DuPart, Current Practices and Recent Advances in ART, which has successfully held conferences in New Delhi and Goa, inviting national and international faculties. She has many publications in her name, and she is invited speaker at various conferences. Now, without further delay, I will turn the time over to our expert for the webinar. Just a reminder, if you have any question during the presentation, please type them into the question box on your screen. We'll bring them up after the presentation. Over to you, madam.
Thank you, Abhijit, for the kind introduction, and thank you, Intas, for giving me this opportunity. Today, we are going to talk about IVF practice in the post-COVID era, and I'm going to share some of my experiences with you all. Before proceeding, I would like to wish Happy Baisakhi to all of you for the Bengali Shubho Poila Boishakh, and of course, all the various wishes all over the country. Today morning, we did hear the Prime Minister, and he has said that the lockdown will continue till the 3rd of May, and he will reassess on the 20th of April to see whether certain openings can be done in various specialities. The pandemic has hit us hard and quite sudden, starting in December 19 in China, and we've heard a lot about it in so many webinars. Droplet, mainly contact spread, but now even spread up to 4 meters is being discussed. It is a constantly evolving virus and disease. It could be asymptomatic or it could cause death. The mortality rate is around 4%, could be as high as 8% also. It affects the vulnerable population, diabetes, high blood pressure, HIV, immunocompromised people at a higher level. Till date, roughly 2 million people all over the world have been infected, and 1 lakh people have been dead because of this COVID pandemic. Now, the government all over the world, the organizations have given their guidelines so that the remaining all of us are not affected, and social distancing has come up in a big way. So they have asked us to stay at home, wash our hands frequently, and not only that, we should not touch the mucous membranes because that's where the infection goes in. Social distancing between about 6 feet to 1 to 2 meters now is being considered. Respiratory hygiene, so if you are sneezing or coughing, please cough or sneeze into a tissue or in your elbow and ensure that the droplets are not spreading everywhere. There was a big discussion whether masks are mandatory or not mandatory, but now masks are considered mandatory, and there's a huge number of masks, and depending on where you are and how much you are exposed, various masks need to be worn. But at least if you're going out into the public, you have to wear even a homemade mask to cover your nose and mouth. Must it's become mandatory. And of course, like I've mentioned, the guidelines are constantly evolving. It has affected the health and, of course, the IVF industry. The guidelines have come that we can only do emergency cases in all specialities. So elective cases are not being done, mainly because we do not know whether they are in the asymptomatic phase, the patients or the healthcare providers, and also the resource needs to be saved for if the pandemic, the number of patients increase. So only emergency cases. In IVF, we've been asked by most guidelines or recommended that we complete the current cycles and preferably not do an embryo transfer and no fresh cycles till the guidelines are reviewed. Till recently, I have not seen any review, but I'm sure we will find a review of guidelines very shortly. So the main thing is that, firstly, with this virus, mainly from the Wuhan province in China, it has been seen that it does transmit to the fetus, but the risk of transmission is less. It's a small data, so we really cannot say what is the exact percentage. And hugely, it is not like the Zika virus, which had caused huge congenital malformation, miscarriages. There's been no report of congenital malformation yet, and of course, the incidence of preterm labor is there, slightly higher when a pregnant woman is infected with COVID disease, coronavirus. So now is the question. Today's talk is basically about the post-COVID era. Now the question is, will there be a post-COVID era? Of course, I mean, we are all optimists and I'm sure we will come out of it. But really, we are now preparing ourselves to face the world where such emergencies hit us, but not so badly. And we want to prepare ourselves as intelligent human beings so that pandemics can be stopped right in the beginning. So this is coronavirus. We don't know whether it's going to come back again. We don't know 5 years from now what's going to happen. So today's talk are my thoughts on how, as a healthcare worker, as an IVF specialist, we may deal with such future issues. So mainly IVF is non-emergent. The question is, should it be non-emergent? The most easy question is, of course, it is not an emergency. You can wait for your IVF procedure. You can wait to get pregnant. There are many other emergency situations. But the question is, how long? How long are we to stop such cycles? We know infertility is an extremely time-taking process. We know there are women where every month is important, and we know the increased stress associated with this artificial withhold of treatment. So not only is the anxiety developing around this withholding of treatment, it is also a huge economic burden. This lockdown, which has come to the country all over the world, in India itself, the burden is about 32,000 crores per day. That's the loss to economy every day. The private health sector is working at barely 10% capacity. People are finding it difficult to get hold of the running costs like their salaries, the rent, salaries to your employees, the rents to the institutions. In fact, many small clinics have even shut down. So we are sure that we will come out of it. And in the morning message by the Prime Minister and the peaks and troughs that are being seen all over the world, it is a question of a few weeks or a few months, but definitely there will be a post-COVID era. And we will open up in stages. We will proceed from emergency to elective, essential to non-essential, but we have to step into this era much, much more prepared than we were before. It cannot be business as usual. It cannot be, because then we may have to face this again, and I'm sure we will not be able to take this brunt again and again and again. So preventive measures are here to stay. And one of the simplest way is to prevent overcrowding and multiple visits. So my talk is going to cover briefly as to how I feel that in an IVF cycle, we can reduce the visits and yet not compromise the results. So I was trained in the UK and was there for about 3 years. And I'm sure many of us have practiced in different places all over the world, in the country, and each one of us may have important points to share as to how this can be done. So I'm briefly going to share my experiences. So there in the IVF center, one of the important things that I could make out is phone handling. So that was the initial, that was around 2004, 2005, the initial era of the mobile phone. The smartphones were still not so much in vogue as it is now. So there were mobile phones. So in the units, mobile phones were not allowed. So you keep your phones, and the phones, the landline phones, are handled by the admin and by the nurses. And it is not the norm to give your personal mobile phones to the patient. Now, this is a very important point. The moment you give over this private number to your patient, you immediately lose the connect that your admin may have made to schedule appointments. So I'll come to that a little later about telemedicine. So phone handling, the admin did all the appointments, the consultants did not share their mobile numbers, and the nurses handled calls like spotting, bleeding, pain, and if they thought that this is not handled, they are not able to manage these, they would then, try it to the consultant. And of course, there is the injection teach. So uh, there were subcutaneous injections. The nurses would take time out and teach the injections to the patients, to their partners. Patients would take injections with them. And it was not a norm to come to the center for all your 10 to 12 injections, or go to a local hospital or nurse or a clinic to get your injection. So this is again saving time, saving transit, and reducing overcrowdedness in the clinics. And scan-based monitoring. Now, there's a whole lot of debate whether you need to measure your estradiol, your progesterone. Some say yes, but mainly in the European countries, most of the IVF treatment is scan-based. So you do your day 1, day 2 scan, you rule out cysts, you see the thin endometrium, you start stimulation, and the number of blood tests done are very few. So again, that reduces your visit to any facility. Also at our center, we have outstation international patients who have a lot of communication before they come to our center for the process, and it enables us to share those experiences, and all of us are handling working couples, and all of us are very mindful that they do not want to spend too much of time at the clinic, or they want to reduce the number of visits. So, I shall broadly discuss on these points to see how we may in the future try to minimize crowding at our centers or clinics. So for that, we need to understand the IVF cycle. I'm sure most of you who are doing the IVF cycle, let's think of from the patient perspective. So where does it start? It starts first figuring out whether they need IVF or not. And once, so that they will take various opinions. then they decide, okay, so I need an IVF. And then they decide which IVF center, which IVF doctor. They want to know the cost, the success rates, what is different about each center, how is the procedure. So a lot of information is gathered at this stage by the patients before they really decide to embark on the process. Now, once the decision has been made, then they come for the assessment. The doctor, goes through their history, does a few tests, and in our center, I would like to do a transvaginal scan of all new patients personally to be sure that we are not missing out anything. So like a fibroid, a hydrosalpingo. So they have kind of decided that they need IVF, then they've decided their center, then they have come for the workup. And once the workup is done, say you have seen a fibroid, you've seen a polyp, you may want to do a laparoscopy or a hysteroscopy. Again, the questions of what is the procedure, what are the costs, do you have insurance, how long do I stay? They may have high blood pressure, they may have poorly controlled sugar, or they may be suffering for thyroid, hypothyroid, or hyperthyroid. So all these things need control before we really start. So by this time, so for these, if they are coming to us for all these, then maybe they've come by 5 visits to really understand the process and get themselves assessed. And then if they've had a problem before doing the IVF, another 5 visits before that is sorted out, and then the real procedure. The procedure, as we know, there is a day 1, day 2 scan, then there are injections, there's a day 5, day 6 scan. So I'm talking about an antagonist cycle. And most of us, we know, are doing antagonist cycles. So again, a day 9, day 10 scan, then injections, then site retrieval, embryo transfer. And if you're, of course, not in all clinics, they do not come for all the injections, but in some clinics they do. And some patients really want to come for the injections. They really want to be sure that the injection is being taken properly. So they'd rather have the nurse give it. So that may amount to about 15 visits in total. So if we slightly go into the donor IVF cycle, again, the process is the same. They have decided they need the donor. They want to know about the procedure. They want to select the center. They have selected the center. The doctor has done all the tests and done the transvaginal scan. And then the doctor may decide that they need some procedure, may not decide, may need to control, especially in older women, you will need control of these chronic illnesses. They are usually in the later part and of the or early part of 40s, where all these illnesses are common, diabetes, hypertension. So they will need a few more, cycles to understand about the donor cycle. Then couple wants to know about the donor profile. So once they want to know about the donor profile, they would like to liaise with agencies. They want to share the donor, see the donor profiles. So they again come for quite a few visits to be sure that the donor, of course, we have to share only non-identifiable features. So they again kind of come for those visits again. So then once that is decided, you have your Lupron, you have your scans, serum estradiol, scans again, and embryo transfer. So that again entails quite a few visits. So by the end of it, we have come to the embryo transfer, and after embryo transfer, she can have spotting, pain. It could be after that, you could have a positive test and you can advise scans, or it could be a negative test and you need counseling and planning the next cycle. This would again entail a few visits to the center. So by the end of it, if you count all of it up to one cycle, there may be up to 30 visits in your center. And if you combine it with the number of attendants, you can only imagine the rush that happens in an IVF center with multiple ongoing cycles. And in any atmosphere where there is a pandemic, we cannot afford to have such disaster. So we have divided all of these steps into where the presence of the clinic is most important, and where they physically have to come to the clinic, where you can do telemedicine, where there can be home tests, where they can do it at home. And then, of course, you have the blood tests, you have them giving the medications, and the OPD can be, when they come to your center, there are certain centers that have a hub and spoke model. So again, you need to think in your mind, if you have such a facility, where can your patients, do they always have to come to the center, or can some of the procedures be done at the spokes as well? So I have basically divided each and every step into either OPD, means physical presence is important, telemedicine, presence at home, and OPD can be divided into hub or spoke. So in this, when we are coming into the IVF cycle, you see that doctor has to perform pre-IVF assessment. That means when the patient is seeking or trying to figure out which treatment is best for them or which IVF center is best, you will have to, all these can be done by a good telemedicine setup. So if the patient calls, you can, of course, to seek the best treatment, whether you need IVF, you will need a medical consultation in the outpatient. But once that has been selected, patient knows that patient has to go for IVF and is choosing. If the patient is convinced or satisfied by the information that you are giving over telemedicine, on telephone or video call, on Skype, you could show a video round of your center, then the patient or the relatives does not have to come again and again to your center. All these, the procedure, cost, highlight of your center can be handled online. Of course, once the patient has selected, one presence is a must, the general physical examination. I'm very particular about the abdominal scar. If we need to do a procedure, whether it's a vertical scar or a horizontal scar, we need to do the transvaginal ultrasound. All those things is important. Now, here is another way in which we reduce the number of visits is once the patient is happy to come to our center, we also, after reviewing all their reports, their current reports, say in the past 6 months or 1 year, after reviewing in the past few months, we give them a list of tests that they need to do, and they can do it locally. We do not insist that all tests have to be done at our center. So that reduces another visit. So the more you increase the convenience of the treatment without affecting its success rate, the better it becomes for the patient. So the patient has come to you with all the tests, you have the history in place, you will examine the patient, you do a transvaginal scan, and then you will decide whether the patient needs any procedure or does not need any procedure. And in the same visit or later on with your able team, everything about the procedure can be explained. If the patient has had high sugar that is not controlled, can be liaised with the medicine consult, on telephone with your referral doctors, and all these things can be handled telephonically or by video calls without the patient having to come again and again to the various centers or the clinics. Now we need to be very, very conscious as to, sometimes we are not, sometimes we just say, okay, call the patient, let the patient come, let's talk to the patient, report leke aane do. For everything we sometimes make this error, not everybody. And I think the time has come where we become more conscious as to when we are calling patients to our center. It really needs to be when the physical presence of that patient is important. Now the IVF cycle has started, and you have the day 1, day 2 scan, the day 5, day 6 scan, day 9, day 10 scan, day 12, day 14, and day 14, day 18. So in this all you on the original scan, the next scan, this you need the patient in your center. Now here again, if you have peripheral centers, or because we get patients from outstation, out of Delhi, we once we have assessed the patient, written down the plan and everything, and the patient is having a regular cycle, does not have irregular cycles, so we do start the sometimes they do start their injections in their local city. Now, of course, there's a huge debate on the cold chain, how to maintain the drugs and everything, but it is a possibility. And the first scan is also done in the city where one of our doctors is present and who lies with us for the IVF cycle and the pregnancy thereafter. So, but this usually does not happen. So, for the first scan and all the subsequent scans, and of course the egg pickup and the embryo transfer, it is important. Now, understand the donor IVF cycle. In the donor IVF cycle, again, the pre-IVF assessment is important. You need to rule out the polyps, the fibroids, etc. And if you do a procedure, even then the patient has to come. And the rest of it, the donor profile, the agencies, everything can be shared through telemedicine. And once the procedure starts, the scanning, etc., has to be done at the center. Now, once there is the positive or the negative, of course, once the cycle is negative, the couple is keen to meet the main doctor, who definitely come to the center. But it's also a question of how you kind of prime your patients as to what to expect if it is negative. You can say that you can report the test results to us, and we can go through your files and then have a telephonic consult, the senior consultant can talk to you and plan the future cycle. So that is an option. Of course, for the positive, the patient may want to come and take medications and then come for the next scan. So that is optional, really. Both the positive and the negative, the test result is really optional. Pregnancy follow-up, we've had a lot of webinars on that, and by that we know that at least till the pandemic lasts, and maybe even thereafter, we need to reduce the number of pregnancy follow-ups, and only when a patient needs to come when there is physical examination or during emergency. Home weight checking, blood pressure, fetal kick count must be emphasized, and all these things can be done without the need to come to the center. So, after minimizing the various steps, patient has come roughly about 20 to 30 times, and we have reduced it to 8 to 10 times. And if you have a hub and spoke model, that means your center is just doing the pickup transfers and maybe the initial assessment, and you have other centers where the injection, scanning, etc. is being done, then the visits can be minimized to 3, even maximum 5. So whenever you are writing a prescription or planning, we always think, when am I calling the patient next? Is it very important for the patient to come to the center physically? Where does the patient stay, and how can we make it more convenient for the patient without affecting the process? So always plan the next step and check if physical presence is essential. So we have kind of made a 5-visit IVF. Now, this cannot be, there is a rider to it. This cannot be for all cases. You know, you may need to do hysteroscopy. There can be so many other things. But if it is a plain, simple, clean cut antagonist cycle with no other first cycle, endometrium is clear, then you do your day 1, day 2 scan or an assessment scan, this is the first visit actually, which is very, very important. And then next is your day 1, day 2 scan to start the treatment. Then are your next 2 scans, and then could be your pickup and your transfer. But if you do one scan at the periphery in your hub and spoke model, so you have the first visit, then you start with the injection, you have the first scan there, and then the next 2 scans in your center, and then the pickup and the transfer. So you can reduce to 5 and maximum maybe 7 or 8 visits. So it's an attempt to be conscious of how many times the patient needs to come and how many other things can be dealt on the telephone or video call or telemedicine. Now the patient has come to your center. The patient needs to, you need to check the patient, talk to the patient, assess the patient. So at least now we are not doing ongoing cycles. But even after the pandemic, as we said, it is very unlikely that it's going to be business as usual. We will have to continue to be careful for a long, long time and maybe forever. So we have to screen for fever, symptoms, and the TOCC screening, the tox screening of where you've been traveling, whether you have a high risk occupation, whether you come from a cluster or community where COVID is, widespread. All this history has to be taken. And in IVF patients, only if these are negative is the patient allowed to come to your center. We usually look through all travel documents. It's just not a history. We check travel documents to be sure that they are not in those areas, coming from those areas. Now it is the OPD visits. This is an important slide, and this is, basically saying how many of us the OPD visits should be only when it is a must. The appointment system must be there. Attendance should not be more than 1. There should be no waiting area. Hand washing, social distancing must be there. Minimum stay in the clinic. Do not touch unnecessary surfaces. And high-risk individuals should not be allowed online payment. So for here, I would like to highlight that regarding our appointment system and attendance and minimum stay in the clinic. Rest, we have already heard that it is happening. Now, how do we get into the appointment system? Many of our clinics and centers, many are appointment system, very streamlined, but I feel most of the others are not. I do, in my own center, I have walk-in patients. So once you have walk-in and then you have their relatives coming to you, you are crowding and your whole system becomes unplanned. So the person or the persons giving appointments, there should be 1 or 2 contact people, and only they can schedule appointments, and there has to be a good time gap between each appointment. I know it's a challenge. I know timing is a challenge in our country. There's always the traffic to blame. There's always people saying we are on the way, we're just about to reach. But I think slowly, as and when we become more disciplined, more firm, universally, the appointment system will come into play. It's just a question of changing everybody's, including our attitude. Then the next is the number of attendants. Now, attendance should not be more than one. So, ideally, in fact, nowadays the ultrasound guidelines which have come up in this COVID era is that the uh, attendant must not come into the waiting area. In fact, some clinics have stopped the waiting area concept. So only the patient walks in, gets done the ultrasound, walks out after the due formalities. So again, that's a huge mindset. We know how our patients, the close family members, the extended family members like to know about the condition, the prognosis, are very anxious. So this has to be slowly discouraged. And I'm sure once we explain to them why, it's in everybody's interest. It's not only the healthcare, it's even the patients, the entire community's interest. So this also is a system that needs changing. The other point which I feel is very important is the stay in the clinic or your doctor-patient interaction time. Now, the distance we have already mentioned, the social distancing, the hand washing, etc. But the interaction time, sometimes the patients are, they have many questions and it comes and goes. It's like a cloud. The discussion and the consultation is not very, compact. So I always recommend that my patients, and it's not just to reduce the time that I spend with them, it's also to make it more fruitful, is to list down your questions. So it is beneficial both to the patients and also the doctor. You do not miss any points and you're also able to minimize the time without any unnecessary interactions or interruptions. Of course, there's a huge impetus on online payments. So cash transactions are hugely discouraged. Paper, plastic especially is where the virus is supposed to stay longer. Even in paper it stays. So anything which will increase your interaction with the virus now or in the future, some other virus. So online payments are encouraged strongly. So what about your area and what about your equipment? So all areas to be mopped frequently with approved disinfectants, appropriate areas, metal surface with 70% alcohol. Keep your connecting doors open so you're not always, everybody's not touching the knobs and handles. So keep the space open, have good ventilation, and all equipment to be cleaned with 70% alcohol. We know the ultrasound tips, alcohol is going to damage. So except the tips that may be done with water or mild Cidex, but rest of it properly cleaned at appropriate intervals. So these are the various disinfectants that can be used, and Lysol and bleach are some of the commonly used ones for your floors and other surfaces. Now the OPD staff, again, you have a lot of people in your office. You have the admin staff, you have the nursing staff, you may have the accountant, you may have the counselor, you have your other nurses, you have your other consultants, so maybe 20 to 30 people working in your center. So we need to introspect and see that which of these can be done from home. Now that's going to be a challenge. So the admin, the appointment, your accounts, your chartered accountant, your counselors. Now counseling is something that both in India and in the West is going on very in the same rate at which it was going on, in fact higher, because people are getting more anxious and mentally disturbed. Why? Because they have the system, the admin calls, the payments are made, the Skype session is booked, and the counseling is done. So if other specialties are able to do, I'm sure even we can kind of outreach some of our work to the rest of the outside the clinic areas. Now, what does the staff have to do? They have to wear only clinic dress. They have to change their home dress to a clinic dress and then change the clinic dress and wear the home dress. This is to minimize infection at home, at their homes. They have to wear the mask. There's a whole lot of debate on which mask. Is a simple surgical, 2-ply, 3-ply, or your N95 masks, and then you need to wear the head cap. So broadly about the mask, if you're not dealing with active COVID cases, a simple surgical mask is enough if you are maintaining the distance. But if you are close doing an ultrasound, your hands have to be clean and bare up to your elbows. You should not be wearing any jewelry, and you should have at least a 2-ply to a 3-ply mask. Now, these are masks that are more dense, and they are more close and do not allow the particles to exit or enter. So a 2-ply or a 3-ply mask for close work, and a simple surgical mask for work at a distance. Every person must have designated areas, and they must not try to mix their mobile phone, keys, everything everywhere. They have to be very, very aware of their items and keep it. They have to hygienate it with your alcohol as they come into their center, and then before going, repeated checking of phone should not be highly discouraged. It should be highly discouraged. We have to stop common lunches, because again, that's where you're close and talking and droplets spread. And like I mentioned, mobile hygiene, key hygiene is a must. So now let's talk briefly about telemedicine. Telemedicine is here to stay, and it is up to us, up to the healthcare professional, whether we can make the best advantage of it or not. The Ministry of Health and Family Welfare has given guidelines that telemedicine can be used, and it is the delivery of healthcare services where distance is a critical factor, used by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries. So this is here to stay. There are various modes in which telemedicine can be done. Video, where the advantage is you can see the person, patient identification is easy, the discussion is more empathetic. Of course, it depends on high density, good internet facilities. There is also risks of abuse and misuse and hackers, etc. Audio is also convenient and fast, but you may miss non-verbal cues, which are very important in decision making. You may not be able to see the areas which the patient may be suffering from, for example, skin. You really need to see. So audio is also good, but it has its limitations. Text-based is convenient and quick, but you are lacking the audio-visual signals, and it's difficult to be sure of the identity of the patient. And of course, you have email, fax, and others. So these all come under the era of telemedicine. Now, 7 elements to be concerned before telemedicine consultation. Why are we doing it? Now, it is the duty of the registered medical practitioner to decide whether this consultation can be done on telemedicine. So, usually it should be done for patients whom you have seen at least once. Follow-up consultations, though there are guidelines for new patient consultations on telemedicine also, but follow-up consultations are always better and safer. And it is your responsibility to decide whether it is the right mode of giving your advice. Then consent. If the patient has connected you on telemedicine, it is implied consent. You don't need to take a specific consent. But if you are approaching the patient, it is you need explicit consent. Patient has to say, yes, I'm okay to go ahead. You have to identify the patient, same patient, name, surname, age, date of birth, address, everything. It's not that you are wrongly giving consultation. And then you will have algorithms. At any point, you might decide that this may not be the right way to give the right decision, make the right decision, or give the right advice, or you may discontinue it at any point. So if you go into the Ministry of Health and Family Welfare guidelines of telemedicine, you will see various algorithms, and it will tell you how to proceed with telemedicine consultation. So there is also, a prescription. After the end of it, you are supposed to share your prescription with your patient. So now there is a slight gray zone, is that the drugs that which can be given on telemedicine, we need some more clarity as to which drugs can be prescribed and which cannot be. Usually the ones that which have already been prescribed, and if you are writing continue, that may be okay. And of course, your general fever medicines, ORS solutions, multivitamins are fine. So clomiphene citrate, letrozole, there is no real clarity on these drugs, whether they can be prescribed by telemedicine or not. But if they have already been prescribed, you may continue with it. Now, is it legal? Of course, it's legal. Like I've already said, the registered medical practitioner has to decide which consultations can be online. If the patient approaches, it is implied. If the doctor approaches, it is explicit. Separate consent has to be taken. Medical legal matters are same as face-to-face consultation. So it is not illegal to give advice, and whatever issues would have been there in a face-to-face, the same stay, and any party can decide to withdraw from teleconsulting. Now, the big question is finance. Now, we all agree that at least in the private healthcare setup, where you are giving your time and expertise for the patient, and where the general public is kind of used to us giving telephonic advices, either verbally and on your WhatsApp messages, and suddenly the healthcare worker or the staff are saying, well, you'll have to pay for this consultation now. It may not come very easy to them. However, if we, this will take time, it's not going to come easy. And I think one of the easiest way to get it done is that the main healthcare provider, I think the mobile number is a very personal information. And the more access you give it, the more you are telling your patient that, yes, I'm available, I'm approachable. And then if you suddenly say, well, now, I'm not going to tell you till you pay me, so that will become a little bit of a difficulty. So now wherever, in whichever cultures telemedicine has thrived, and believe you me, it is the need of the future, and it is here to stay. Your admin and appointing system has to be separate, and your patient has to only consult them. You can share your email ID for other information so that you are in touch and it's not that you're completely blocked from your patients. And you can have signages in your private practice clinic that these are the reasons, these are the advantages, and I'm sure patients will understand and sometimes appreciate, because that's what they want. They don't want to stick in the the traffic jam for hours together to reach you. So we have to make them familiar with telemedicine. It's telephonic consultation with doctors has till now usually been taken for granted. We'll need a whole attitude shift. We'll need a special protocol and discipline. And there are various online Paytm, bank transfers. All these can be done. Where it's being done successfully is first the patient makes the transfer, and then you give the consult. Now you have to be wary and empathetic as to which would be the paid consults and which advice can be given otherwise. So there are very small issues that I'm spotting or bleeding. So that's a little bit of empathy that when we find it's okay. But suppose you have to, the patient really wants another discussion on a failed IVF cycle, which they've had elsewhere, and they've come to you, they're deciding. They don't have to come all the way. You can say, okay, let's fix up another time, and I'm happy to share with you and answer all your questions. So all these things can be planned beforehand. It reduces travel time, it reduces pollution, it reduces stress from travel, overcrowding, and pollution. You can take it anywhere. You can save patients a visit to the office. A patient may otherwise not have come thinking of the distance, but telemedicine can make them easier to approach you. You can expand your catchment area. You can alleviate some time constraints associated with in-person visits. The cons are that physical examination is limited, potential loss of personal contact with the patient, potential reimbursement issues. So time has come to change the way we practice. We need to change the current trends of private practice and expectations of healthcare workers and patients. We need to be very mindful about minimizing crowds, minimizing the number of visits, minimizing attendance, time spent in our outpatients, and take preventive methods applicable to both the patients and healthcare workers for a long, permanent way. And telemedicine, my dear friends, is here to stay. So let's continue our work, modify our practices, and eradicate the pandemic. Thank you very much for your kind attention. Can't hear you, Abhijit.
Madam, I will thank you for such a wonderful lecture. Now we'll take some questions, madam, with your permission.
Your voice is very low. I can't hear.
Hello, madam. It's time for question and answer session, so I will take some questions for you.
Can we stop share?
Yeah, you can. Hello. 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 Can you hear,
Yes.
madam? Yeah. First question is from Dr. Alka Jain. She's asking, what would be the safe time to initiate conception in post-COVID time?
Now that's a very, very important and good question, because till now we do not know what is the incidence of transmission of COVID to the fetus and what are the damages that it can do. So till now, the data is being evolved. The data so far, till very recently published in JAMA, was that there is a risk of transmission, but it is very low, somewhere in less than 1 to 2%. And the only risk in pregnancies is preterm labor, the higher incidence of preterm labor. So obviously the question, the international question that is coming up is that the guidelines have stopped IVF, but we cannot stop natural conception. So what is, of course, the rationale is that IVF means interaction, coming to the center, and maybe that is why you want to prevent COVID. So coming to your answer, so the natural conception all over the world, of course, many people who are very, very concerned are using contraception even now, but generally people are still going ahead with natural conception. So I think we will have to wait for a few more weeks or even months to see what is the impact of this virus in the pregnancies. The literature, the studies so far is quite positive and encouraging.
Okay, madam. Next question is from Dr. Shaunak. He's asking, is it okay to do IVF stimulation, egg retrievals, and embryo freezing during these times?
So again, we are going with the SRM, ESHRE, and the FOXY and our national ISAR guidelines that when the lockdown started, which was about 3 weeks ago, the recommendation was that ongoing cycles can be completed. If it is not an emergency, embryos should be cryopreserved and no fresh cycles should be started. So till now, as far as I'm aware, there has been no change in this guideline. But what my talk has been on, and I'm sure many people all over the world and in our country, in fact, I'd heard a webinar by an Italian doctor a few weeks ago, and everybody is thinking, how long should we stop IVF? So the guidelines are emerging. We'll have to be patient, and till fresh guidelines come up, we will have to withhold fresh cycles.
Next question is from Dr. Sushil Shinde. He's asking, recent paper by NIRH and ICMR states to avoid IVF treatment to the minimum. How to define what is minimum once the lockdown is over?
Yeah, so again, as I said, we have to really understand what are the guidelines trying to tell us. Now, again, the question that the debate can be, why only IVF pregnancies and what about natural pregnancies? Are we really worried about the conception? Then we should be worried about both natural and IVF conception, or are we worried about the crowding or the contact of this non-emergent treatment? So, so far, there has been no guideline on natural conception. So, probably the general consensus so far is that the affection of the COVID virus is not to a great degree, but we are not sure. So, your question is, if the lockdown is over, then I'm sure there'll be guidelines coming up for slowly starting IVF cycles. As you know, our patients are very, very worried and they are all keen to know when we can start the treatment. We are, at least in our centers and many of our doctors, we are waiting for guidelines to come up, and obviously till the new ones come, we cannot start.
Yeah, there is a question from Dr. Jasneet. She is asking, in case of NRI patient insisting on FET, can we take her consent and go ahead?
So I would say the answer to that may be a yes. The reason being, of course, you will have to write it in black and white, because this couple may not stay for a long time and cannot wait, and has come specifically for the treatment, and ideally would be not to transfer. But if the couple, especially outstation international patients who have just come for treatment and you have waited the 3 weeks of lockdown, it is a humanitarian point, and you may go ahead with consent that they agree that if anything happens to the fetus, they have been explained that the consequences of COVID virus on pregnancy is unknown.
Yeah, madam. Dr. Shilpa is asking, what is your advice to people seeking consult at this time?
Consult
At this time.
So I presume it is a consultation for a pregnancy. And again, there is no guideline saying that we cannot have normal conception. So we are giving normal routine consultations as far as dietary advice, etc., and natural conceptions. But a rider has to go from healthcare professionals. We have to tell them that the pandemic is still ongoing and we are not sure still. It is encouraging, but we're still not sure whether it's going to affect your baby or not. It definitely is not like the Zika virus, where the incidence of congenital malformations are very high.
Next question is from Dr. Deepa. She is asking, she has one patient who has already undergone one cycle before lockdown. When can she resume further treatment?
I would say we have to wait. From what it appears is maybe in about 2 to 3 weeks, non-emergent healthcare will also open up. But that is optimistic. That's an optimistic way of looking at it. Many people have said months, July, August. But personally, I'm of an opinion that we cannot treat infertility as non-emergent, especially in a select, category of patients. For example, depression, anxiety, they have access to psychosocial counseling. But what about infertile couples, and how long can you go on telling them that this is non-emergent and we will not do your treatment? And they are say around 38, 39 or 40. So I'm sure guidelines will come up where slowly we will be able to approach these couples and help them. But we have to be very, very careful about whom to allow to enter, how many people, etc., which I have just given a discussion in the presentation.
Dr. Tejasri is asking, are there any AI-based ultrasound probes developed for telemedicine? What is your opinion if something like this comes up?
So in our country, definitely because of the PCP I am quite sure that is not going to work. And the implications of telemedicine, though it's very, very useful, but we know the other aspects of the society and the ultrasound being available at this level to everybody can be very, very dangerous. And we have still not yet been able to fight the war of gender discrimination. And personally, I feel telemedicine ultrasound, India is not mature enough to get it on board.
Next question is from Dr. Monica Singh. She's asking, do you think we can start our cycles in May, or should we have cycle of OCP or estrogen?
Personally, I'm withholding for another month. So I am asking all my patients to wait till the next menstrual cycle. I do not think giving OCPs improves pregnancy rates in antagonist cycles. So, so yeah, I think we need to wait till all international and national guidelines and bodies give us a green signal.
Dr. Tarini Taneja is asking, time for telemedicine is at patient convenience whole day or some defined time period?
Greetings, Dr. Tarini. Really nice to hear from you. Telemedicine should be time bound. It cannot be whenever at whosever convenience. The reason it needs to be time bound is you're able to kind of schedule your discussion properly. Think about the points that you need to discuss. You are free to talk to your patient. You are not already busy or occupied doing something else. So telemedicine consults have to be very nicely booked, the time slotted, and about 15 minutes time slot. You can start from 9 a.m. and give 15 minutes time slot. So yeah, it cannot be as and when. It has to be by appointment.
Dr. Manisha is asking, please tell us precautions for handling the USG machines when we are doing TVS.
That's another good question. And the International Society of Ultrasound has given certain recommendation as to how to manage your machines. So say you have a machine with 3-4 probes. It is best now not to keep all the probes outside. So keep only the ones that you want to use outside and clean them as frequently as you use it. The reason why you do not want so many probes outside is you may miss the used probe and not clean it and then use the unclean probe. So keep only 1 or 2 probes, use minimum jelly, clean the gel after your use. The entire length of the tubing or the wire can be cleaned with 70% alcohol. The tip of the transducer probe has to be cleaned with water and even mild Cidex solution. We know alcohol can damage the probes. And in the strategy of safe ultrasounds, first is just skin touch ultrasound, which is your transabdominal ultrasound. Then is your orifice ultrasound, say your transvaginal ultrasound, and then is your intervention ultrasound. So the safest is your skin touch ultrasound in the COVID era, and then TVS, and of course your interventions. So as much, of course, in infertility, fertility practice, we say TVS is the best thing because that gives us the best information. But now, till we are in this era and we are kind of moving out of it, if possible, try to minimize your TBS scan because that's when you're putting in the probe, you're taking out the probe and it's getting touched by mucous membrane. Your healthcare worker is using it. So I'm not saying don't do it, but do it with judiciousness and wear your protection, wear a double layer or a triple layer mask and everything while you do it.
Okay, madam. Dr. Nazma is there. She's asking, are there any additional risk for surrogacy at this time?
Now, that is a very, very important question. Surrogacy, yes, I mean, centers that are doing surrogacy cycles are experiencing the challenges. I mean, it is the visits of the surrogate because to a patient who knows everything about it, who's aware of it, you can explain, you can call, you can share ultrasound images on WhatsApp. But with the surrogate, that's going to be difficult, and you need to make her travel sometimes to get the right information. And then, you know, how difficult it is traveling nowadays, we all know. Then, of course, it is about her hygiene and whether she's really practicing all that or not. So, yes, the healthcare workers and the intended parents are quite tense these days.
There is a question from Dr. Preeti. She's asking, how do you ensure that IVF lab clinic does not get contaminated with coronavirus?
Now, that's another good question. You know, like the vaginal probe cannot be touched with 70% alcohol, that's a few things. You cannot fumigate. You cannot bring alcohol to your lab. So all these things kind of make us a little bit you can clean your OPD surfaces, you can clean your waiting area, but what about the lab? So currently what we are relying on is our air handling units, the air circulations, safe, which is benzonium chloride, washing and cleaning. So these practices that were there earlier are also being carried out.
Thank you, madam. Thank you for sharing your expertise on this very important topic in a very crisp way. I'm sure audience has gained a lot of insights. I'd like to thank all our participants for taking out their time for this webinar. I'd like to thank our BU head, Mr. DP Satpathy sir, and our divisional head, Mr. Manish Shah sir, for making this event possible. Have a nice day ahead. Thank you, ma'am.
Thank you. I'd like to thank your team, Mr. Satpathy in task for this wonderful opportunity. Thank you so much.
Thank you, ma'am.
Thank you, madam.
Thank you. Thank you.